buenos días tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida a la sesión académica de pediatría. On behalf of the School of Medicine and Health Science of Tecnológico de Monterrey, I give you the most warm welcome to our weekly Pediatric Grand Rounds. Today we're gonna have the first of 4 sessions on developmental and behavioral pediatrics, and the first one is gonna be held by Dr. Mendelsohn, and I'll give the floor to Dr. Juan Francisco Lozano, so he could be the one who introduce our guest speaker for today. Dr. Lozano.
Gracias, doctor Valencia. Pues bien, soy el doctor Juan Francisco Lozano y hoy tengo el honor de presentar al doctor Alan Mendelsohn con su tema que hoy nos va a estar platicando sobre la importancia de promover el desarrollo de los niños desde nuestra comunidad y la práctica de pediatría. El doctor Mendelsohn es un pediatra del desarrollo y comportamiento, profesor de pediatría en NYU, en la Universidad de Nueva York, en Grossman School of Medicine. Tiene un amplio repertorio y grants en relación a investigación en las disparidades relacionadas a pobreza, en el desarrollo infantil, en conjunto con condiciones crónicas que incluye la obesidad. Es un pionero en un programa que tal vez muchos han escuchado en Estados Unidos que se llama Reach Out and Read y ha desarrollado en conjunto con su equipo de investigadores un modelo que se llama Play Read BIB, el cual esperamos poder conocer el día de hoy, y otros instrumentos que ayudan al monitoreo y la investigación en el desarrollo. El doctor Mendelsohn pues es un líder en el área y es codirector para la Academia Americana de Pediatría en el Consejo de Early Childhood y es parte del comité de investigación. Además es chair en pues es una sociedad, un grupo de investigadores en relación a la pediatría del desarrollo y codirector también en la división de pediatría del desarrollo y pediatría general. Ha recibido varios grants y numerosos proyectos que tiene, además de premios. Entonces, so Dr. Mendelsohn, it's an honor, as we were talking earlier, to have you here with us. So we leave you the floor, and so we can change the screen so that you can share. So the floor is yours. Thank you, Dr. Mendelsohn.
Okay. Well, first of all, thank you for that really nice introduction. And I'm very much honored to be here and be part of your Grand Round series for this month. The title of my talk is Promoting Equity in Early Child Development through Pediatric Primary Care and Partnerships with the Community. By way of background, I'd like to begin by commenting that child poverty, systemic racism, and toxic stress together represent interrelated contributors to lifelong adversity. What I'm showing on this screen is 3 different policy statements that I think have a lot of relevance from the American Academy of Pediatrics, one on poverty, one on racism in child's health, and the third, which I really recommend you all read if you're going to pick one, is on preventing childhood toxic stress and promotion of early relational health, which will be very relevant to today's talk. We know that poverty, racism, and toxic stress have numerous consequences for health and well-being across the lifespan. And my focus has been on early child development and school readiness. And that is both because they are common, both in the United States and worldwide as challenges, and because of the long-term impacts on health, mental health, education, and well-being long-term. The definition of school readiness is broad. It includes what you would think is school readiness, the child's cognitive development, language, early literacy, social, emotional, etc. But it also very much includes readiness of the family, schools, and community to support the child as they enter the educational system. One thing to be aware of is that as I had mentioned, school readiness is a highly prevalent and really central outcome of early childhood that is affected by the factors that I had mentioned. This is a slide sort of distinguishing between families categorized as poor or low income compared to those who are non-poor in terms of likelihood of failing to be ready for school in one or more domain. And you can see approximately a doubling of the percentage based on income. And similarly, this is again US data, but these early disparities translate to long-term educational outcomes. And so the exact same pattern happens as children, again, from US data move through school. And this is showing a more than doubling of the percentage with reading difficulties in fourth grade among those who were meeting criteria for poverty or low income in the US. COVID-19, has definitely been a very big factor for everybody. I mean, regardless of income to some extent, with a large drop in a large hit, I would say, for just about everyone. But there's been a rebound in school achievement by children. However, actually, that rebound has been less pronounced among low-income families. And therefore, actually, if anything, the gaps have widened since COVID. I'm going to sort of talk about 4 key elements that are critical in our efforts to promote equity in school readiness. And these are primary prevention before problems emerge, population level access in early childhood, use of evidence-based strategies, and working across platforms and sectors. And we should have plenty of time for Q&A, assuming I've timed this correctly. So first, primary prevention before problems emerge. So what is this? I mean, it is what it sounds like, right? In epidemiology, there's primary, secondary, and tertiary prevention, where vaccination maybe is primary prevention, right? And same thing here. And this idea, although we think about it with vaccines and in other circumstances, we often don't think about it in terms of early child development and promotion of early child development. And especially in healthcare, this has been left out. And yet there is vast evidence that if you want to have the biggest impact, the way to do that is to intervene early, again, before problems emerge. The second is that we actually know who is at most risk for adverse outcomes and therefore can do something about it, and in this case, poverty. And third, we'll just mention that there are conceptual models that really support the targets for intervention. I sort of mentioned the third one. So just to give a little bit more background on this, there is a vast amount of data demonstrating that disparities begin basically as early as you can measure them. Some of the earlier data was from the team, the authors Hart and Risley, which was a very small study and a somewhat controversial study, which followed families with high socioeconomic status, low to middle socioeconomic status, and very low socioeconomic status. And what you can see actually is that this is looking at cumulative vocabulary words based on age. And you can actually see some distinction, some gap emerging, like as soon as children say their first words, soon after the first birthday, which is crazy. And as I said, although there are 1,000 problems with the study, in fact, the study has been replicated in numerous populations and using numerous methodologies. So what I'm going to focus on is early relational health, by which I mean the quality of relationship, structure of within the relationship, like routines, and in particular, positive parenting practices like reading aloud and play, which are really represent both sort of a place where poverty and racism have major impacts, and therefore and those impacts being a major contributor to early disparities, but also represent a key opportunity for supporting resilience, as we will see. So there are two kind of pathways that kind of lead to early child development and school readiness, and they do so. I don't know if you can see my cursor, but through relational health or early relational health. One of those pathways, just again to note that there are these theoretical models out there, and I think they're useful to think about. One is called the family stress pathway, and here we can sort of link challenges in early relational health to adverse childhood experiences, and all the different kinds of things that you might think about related to family stressors on the one hand, resulting in parenting stress and mental health challenges for families under stress on the other. And this pathway is postulated to primarily act on reductions in self-regulation and social emotional development. The second pathway is called the investment pathway. And here, the linkage is between the kinds of things that go with investment, money and time, education, literacy, and neighborhood resources, all ultimately creating challenges for families to engage in activities, primarily but not entirely verbal and cognitive, like reading aloud and play, that are ultimately related to cognition and language and early literacy. And in a sense, the main way in which this pathway acts is through is kind of the opposite. If one is through adverse child experiences in the stress pathway, this is really acting through what we'll call positive child experiences, although there are many definitions of that term, such as reading aloud and play and teaching and talking. Okay. One thing that's really interesting is that these pathways do not in the least work in isolation. And I think, as you're hearing about these pathways, you might even be saying to yourself, these are definitely not separate from each other. They're not. We have some pretty good data from our experimental work. So it's actually very strong causal data showing that when you support early language literacy and play activities, or those positive childhood experiences, and thereby support reading, play, teaching, and talking, that you can not only, that when you enhance the parent-child relationship, you're not only going to enhance language and literacy, but you can actually reduce social emotional challenges, such as externalizing problems like hyperactivity and disruptive behaviors. Now, and the importance of that past slide is that, there really is this crossover. Everything works together. I want to sort of show another way in which everything works together. This is really, really cool and important work from Christina Bethel from the National Study of Children's Health, showing that positive child experiences actually play a really big role in buffering against adverse child experiences. And what she showed is that, if you look overall on the left among families with, lots of ACEs, the percentage who are quote unquote flourishing is really reduced compared to those with, let's say, none of these ACEs. And yet, regardless of whether you have ACEs or not, positive child experiences improve the likelihood of child flourishing. And in the case of those without ACEs, if you don't have positive child experiences, you actually don't do well. You do kind of comparable to those with ACEs. And among those with ACEs, if you have positive child experiences, you actually do a lot better, almost 3 times better, and begin to be in the range of those who didn't have ACEs in the first place. So this is a really important study in my view, and there are replications of this as well. Okay. So the second topic that I'd like to cover, I'd like to talk about briefly, is if you're going to have impact, you actually have to reach children. Okay, and so a core question is how do you do that? And obviously, there are lots of ways to reach families with young children, but it's not completely straightforward. And it's going to be different, in the US and globally. And I've had, the opportunity to do some global work as well as work in the US, and we'll talk a little bit about that. But nonetheless, to comment sort of on, US data, it's really hard to actually reach families with children 0 to 3. And in interventional services that have happened, like Early Head Start, it has capacity to serve 4% of eligible families. And while home visiting has made substantial progress, certainly families are in their homes a lot, they're nonetheless, the capacity is huge. It's probably home visiting in the US reaches like 2% of families who would benefit. So it's kind of crazy. And in the US, I would say that pediatric primary care not only has been underutilized historically, but I think is increasingly recognized as probably, one of the best places to reach everyone because, as we all, know, children have to, certainly at a minimum receive vaccinations. And to the extent that happens in the healthcare system, it's an opportunity to reach families. We can build on existing relationships that we establish and with parent goals. I'll just say that my background is both as a general pediatrician and a developmental behavioral pediatrician, and the opportunity in primary care to connect with families is substantial in my view. And then one can actually act at low cost because families are already there, so one can actually deliver at lower costs than say through home visiting. The next sort of broad topic that I kind of want to talk about, and I'm going to spend a bit of time on, actually quite a lot of time on this, is the need for and the use of evidence-based strategies in healthcare. And so I just want to kind of comment on if you want to do something to prevent these disparities from occurring, and you want to support early relational health as a way to do it, and not as we'll see, not the only way, but an important way, is that, and I'm just listed some strategies that I think are really important here. One is sort of early learning resources like books and toys. It's really hard to talk to like a 12-month-old for very long. And, or an 18 or even an 18-month-old. And, books and toys, provide props that I think are really important for supporting those language-based interactions and those positive interactions. Second is that if we're going to enhance knowledge, we need to really think about health literacy. Third, and maybe most important, and some very important certainly, is utilizing strategies that really build self-efficacy and skills. The jargony term here is reflective practice, but this could be modeling, video feedback, as I'm going to talk about both of those. Being strengths-based, being family-centered, and engaging in planning. Fourth is building relationships between ourselves, and that's critical no matter what. And the fifth, which is really, really important as well, and equally important, is addressing family challenges and thinking in a two-generational way. Can we address social drivers, even as we're thinking about working with families directly? And I can talk more about that during Q&A if you're interested. So in primary care, I would say that the most studied, proven application of those strategies is Reach In and Read. I know that Reach In and Read has a global footprint. I don't know whether, actually I should have asked this in advance, whether this program is at your site or associated sites. But the program includes waiting room volunteers and staff who model reading activities, and then healthcare providers counseling parents about the importance of reading, and distributing free children's books to support actually engaging in reading at home across the birth to 5-year period. This was developed in Boston City Hospital in 1988, and subsequently reaches more than 4 million children. Yeah. So I just want to quickly go through the data because I think this is really important. There are more than 15 studies showing impacts. Some of those impacts have come from Pam High and her colleagues in Rhode Island, showing that almost a tripling in the rate of reading aloud more than 3 days a week. And then that same group showing in a sort of a quasi-experimental, but nonetheless very robust trial that both receptive and expressive vocabulary increase rather dramatically in the context of the Reach Out and Read program. And they were actually even able to show that children learn the specific words that are in the books, which was pretty cool. We were able to show in a study with preschool children a 3 to 6 month advancement in preschool vocabulary. And this was done at Bellevue Hospital, where I am in New York City, together with colleagues at Mount Sinai in New York. And then more recently, there's like a huge study that came out of North and South Carolina, where like surveys were given to just about, to almost 100,000 families. And what they were able to show is that among 100,000 surveys across 400 sites, that there was, roughly an overall 10% increase in the rate of reading aloud with children every day. So to see this at population level, I view as a big deal. And then we'll just mention a recent study, which I was a part of as well, from Manny Jimenez, who's a developmental behavioral pediatrician at Rutgers in New Jersey, that, books alone aren't sufficient. Because, we want to give out books, and books are great, and we should give out books. But giving out books in this work was shown to have far less of an impact compared to adding guidance to books, which is this bar in blue, and then adding modeling, where giving all three clearly had the largest impact. So as we think about design, I think it's not just about learning materials and not just about books. It is about supporting families in all kinds of ways for their engagement with their children and their relationships with their children. Okay, I want to sort of say that, I sort of mentioned that Reach Out and Read now reaches more than 4 million children in the US, and it reaches children in multiple countries across the world. But really, it's proven that, a really low cost program, right, can actually be effectively scaled, for universal access and engagement and support at population level. And that's really like, we talk about, often we think, well, what we do is not really rocket science, but it kind of is. Like how you reach all families is not straightforward, and Reach Out and Read has done it with big impact. Okay. I want to mention that there are lots of programs out there that have sought to in various ways. They're all different from each other, and they all complement each other. And they think about, they're sort of targeting different goals. They have different levels of scaling, different levels of primary care and integration. But there are lots of programs that are now out there looking to kind of build a model together for high impact intervention at population level. I'm going to move on to some of my work. In addition to my work related to Reach Out and Read, I've had a very strong focus and thinking about, well, how do we layer additional services on top of Reach Out and Read, and how do we enhance impacts? And out of that came a program called Play Read VIP. And I'm going to talk in some detail about that now. I'll mention that if you've heard of Video Interaction Project or VIP, the program was renamed Play Read VIP this year. So any of the studies that I'm about to show relate to this, even though they may use the earlier name. So what is the core component? The core component of this is real-time video feedback in healthcare as a mode of supporting parent self-reflection and self-efficacy, as I described before. So there are basically 3 components: a brief or like 3-minute video of the parent and child interacting with a book or toy provided by the program, immediate review of the video and in real time with the parent to reinforce strengths, and using this to empower parents to develop their skills, leading to improved child development. And I'm going to sort of note that there are a number of innovations to this, which has sort of, I think, led to both impact and the work that ultimately resulted in the work that I've done and sort of thinking about implementing and scaling. The first is the capacity to reach all families at low cost. And to engage families, not only through delivering healthcare as the main means that we've used, but also through a non-clinical coach who can engage with the family in a strengths-based way and be non-judgmental. We've really been able to show that you can do this feasibly, giving a brief video with real-time review, and this is designed to be specifically cross-cultural and very much tailored to families' goals. This isn't about our telling families what to do; it's about building on their goals and support. And actually, the way that's supported is through a structure that's here. The visit kind of consists of work to kind of scaffold the parent around observing their experiences, what they've noticed with themselves, with their child, what they've really valued. Within that, there's some organic discussion of developmental milestones together with activities. But then the core is kind of goal setting with the family before the video, reviewing the video together, and then developing a plan for home together. These are examples of learning materials. You notice that what they are not is electronic. I see that Jenny Radesky is going to be talking to you later in the month about that may have some relevance to this topic. So I'm just going to sort of show you what it kind of looks like in terms of how the video recording is made. But the goal here is to watch it together. You can actually see this. We've been doing this for a little while, so this actually was some of our earlier technology. But positive interactions are observed and reinforced. Additional opportunities for interactions are identified, and the family takes home a copy of the video to watch themselves or to share with their family. I'm now going to show you a video briefly, and hopefully you can hear it.
When she makes sounds, imitate those sounds and then expand on it.
She loves it when I talk to her.
I love it. She's clearly communicating with you that she loves your voice. This is a book. It gives you a lot to talk about. It gives you lots of colors. You can talk about the sound. There are different textures, so you see how things change.
What's that, a little bear? A fishy. What color's the fishy? It's pink, right? Your favorite color besides purple?
You're constantly talking to her throughout the whole sharing of the book. It's pink. I love this part. You related it back to something that's very much to her.
It's purple.
What would you like to continue doing with her at home with the book? What would you do?
The same thing, play with her, show her the different colors. Oh, and also echo some make up stories,
Absolutely. See you soon.
Say bye.
Bye.
I'm just going to mention that capturing that aha moment was remarkable, that we were able to capture this. This was not scripted, and we were so excited to be able to show that, because that is, of course, the point of the program. I've had the opportunity to lead and do a great deal of research related to this, including 4 randomized controlled trials, including more than 1,000 participants across 3 cities in the US, and with large statistically significant effects and impacts following a single visit and quite a few publications. The impacts and a lot of this work has been NIH funded, National Institutes of Health. Impacts have been sort of across domains. First, where you'd expect them, more positive child experiences, reading, play, teaching, and talking. We'll just note incidentally that's actually secondarily resulted in some reductions in maybe negative or adverse child experiences, as in some reductions in screen time and physical punishment. We've actually sort of shown that as you increase reading and playing, that may actually do a little bit of crowding out of screen time. So that's pretty cool. Second, we've shown enhancements in child development. This is sort of across the board in cognitive, language, literacy, and social emotional. And in the US, some reductions in need for early intervention referrals and evaluation. Third is we didn't, this is not really a target, but we find also that as families engage in more positive activities and have more positive experiences with their children, they at least cope better with the demands of being a parent. This is not a therapeutic program, but there is some reduction in maternal depressive symptoms and some reduction in parenting stress, which is probably one of the mechanisms for reductions in physical punishment, and even some evidence of increased coping with COVID-19 related stress from our qualitative work. So actually some of our global work too. Finally, we'll just mention that there's been we have evidence of not only high engagement, including among some hard to engage families, who find this, powerful, strengths-based positive, but also participating in sort of a safe, positive program like this has led to some engagement in higher intensity programs. And I can share any of these articles if you want to reach out following. So I'm just going to show a couple of quick data points. One is that the program, it was originally developed as a 0 to 3 program, and what we were able to see in a sort of complex design study is that for social emotional development, that there were sustained and fairly substantial impacts on social emotional development 1.5 years after the 0 to 3 program was completed. We subsequently developed an extension of the program. We're mostly using the 0 to 3, but the extension actually doubled those effects, those reductions on behavior problems. And then in some of our most recent work, an article by Liz Miller at NYU in Child Development that came out this year has shown that delivery of the program primarily pre-pandemic, this is a complex design again, but nonetheless, delivery pre-pandemic was associated with impacts on vocabulary and early literacy at age 4 following pandemic onset, and that these impacts are indirect impacts. So it's the degree to which the program is enhancing positive parenting and early relational health in the infant to toddler period then results in an indirect impact on child vocabulary and early literacy at age 6. What's really interesting, and we're just doing the data analyses now, is that we're just writing this up now, is that actually these findings are sustained through age 6 after children enter school. And not only that, but they extend to include in the literacy area, both letter word reading and phonics. They extend to some early math, and they extend to elements of self-regulation, such as attention regulation, critical for learning when children enter school. And then I just want to mention this study too, which is as we've sort of thought, as we sort of worked in implementation settings, so out of RCT settings, we might not give the same level of dose as we would in an RCT, but and we don't need to, and I can sort of talk about that in a minute too. It's not designed that you have to go to every visit. I can talk about that later, but we see actually some impacts on parenting behaviors after a single dose, and then even more after 2 visits. So and then I'll mention that the qualitative work has really supported the quantitative work. What families report is that they really think about their son's growth in a different way and really understand their role and understand that they see things that are good and they feel more connected with with their child. So everything we would sort of hope for. I'm going to talk now briefly about some of our adaptation work, which we've done a fair amount of. So it's interesting. I sort of thought of this as, okay, we're just going to do the 0 to 3 program, and that's we'll do some research, and that's that. So the first thing that happened is we began to think about implementation, and I'll tell you more about that generally. But the other thing is that has come up now hugely has been the need to adapt, the critical importance of adapting across lots of populations and characteristics. So that's included language and culture. We've done work in the program was originally developed actually in Spanish and in English in the US. Subsequently, it's been adapted for Mandarin Chinese, and it's been adapted for in Portuguese, and part that's due to work that we've done in Brazil, which I'll tell you about in a minute. We've done some adaptations in the context of adversity, including substance use and foster care. We've done some adaptations across platforms so that we've delivered outside of healthcare, including in community centers and home visiting, and in the context of early child education. We've delivered we've delivered in group settings, and we've delivered through telehealth or remotely. And have in progress, we're working, thinking about families with children with developmental disabilities and other populations, including rural populations in the US anyway. I wanted to just kind of note that this has become such a area of focus that I thought it would be interesting to kind of show the group the way we've kind of approached it. I think there are different ways to approach this, but we've approached it through, engaging in a needs assessment, sort of understanding what needs to be adapted, really using implementation science models like the FRAME model to track changes as we make them, piloting them, involving doing rapid cycle quality improvement to refine them, and ultimately evaluation. And so with that kind of in mind, I want to talk now a little bit about our work in Brazil. So we've done an adaptation of kind of elements of Read, Chat, and Read and Play, Read, VIP to a childcare-based group model in Brazil. These are some of the, and I've actually published fairly extensively on it. The design was initially something called Universidade do Bebê, or UBB, which was a mayor-led early childhood initiative in a city. You can see that red dot, which is Boa Vista, at the northernmost point, one of the northernmost points in Brazil. We worked with educational childcare centers called Casas Mai, serving 2 to 4-year-old children. And the core components of this was a combination of kind of a book lending library system, so families could have out like 2 books and then like return them and get others, and then workshops where families got together in groups of 15 to 20, 25, we provided support for reading aloud in those workshops. And we did a cluster randomized controlled trial with 22 centers and almost 600 families. And we have shown impacts actually across the board. Just to give some examples, one is in receptive vocabulary. Again, this was a cluster trial, so if we look at the groups at baseline, they were pretty similar, but there were some large differences in follow-up. And then this is showing differences in IQ. And one interesting finding is that this is something that sort of worried me as we've done all of the work on Read, Chat, and Read and Play, Read, VIP is, there are many parents who really have challenges to reading. And what we found is that there were actually comparable impacts regardless of parent literacy. In fact, so that was regardless of literacy. We saw changes in parent behavior as well as in changes in child outcomes. And you can see receptive vocabulary and working memory here. The second study, we did a replication in a city called Arco Verde, which we did actually, the prior study was 2 to 4 years. This was from prenatal to 2 years. And we've published on that as well. And what this showed is it extended findings into the 0 to 2 period, and it showed that prenatal, that there were impacts of working with families prior to delivery of the baby, actually. The third study is in Santa Maria in the south, and that was a remote Play, Read, VIP adaptation where we looked at feasibility and did a pilot efficacy study with results showing enhancements in a measure of cognitive stimulation that are fairly robust, and is sort of a paper that's been accepted provisionally. I want to mention that as we think about the adaptation process here, I think I won't go into detail about this, but we think about adaptation sort of across the board. You know, what happens in timing, in platform, in books, in you know, what is it that is most important and salient for families, you know, et cetera. Oh, I'm sorry, I'll just mention the fourth study. The fourth study is actually working with preschool. So we actually worked with teachers as well as family, as well as families in delivering this. And that's also in preparation. Okay, I want to, as sort of the last section, I'm just going to check the time, but I think I have just enough time to do this. I want to note that, you know, this kind of work like just requires a lot of thought about different programs, different platforms, different targets. What are we trying to do? How do we get to, you know, sort of complementary, you know, synergistic program delivery that results in, you know, population level outcomes. And doing that, in my opinion, requires working across disciplines and across platforms to do it. It's not just us in healthcare. It's not just for those of us who are pediatricians. It's not just us as pediatricians. And my team is a highly interdisciplinary team, actually, including people who are developmental psychologists, general pediatricians, and others. I want to mention that in the US, there has been a lot of work on thinking about layered services, integrated models. I listed all of these here. I obviously don't have time to go into all of them, but I'm going to cover just for a minute the first two. So first, I'd like to mention the Smart Beginnings integration. And we've published a great deal on this, actually. And this is an integrated tiered model linking PlayRead VIP as universal primary prevention in healthcare, right, delivered to potentially all families at well-child visits, that's tiered with targeted, focused secondary, tertiary prevention. So addressing families who are already having, you know, challenges or et cetera, and doing that through a home visiting, more clinical-based program, in this case, called Family Checkup. And we've now been doing this for a number of years as well as part of NIH-funded work. And what I can tell you is that we have a lot of data showing actually both short and long-term outcomes. But the one I want to kind of really show you is that the idea of having multiple programs, the first reaction to that is, well, you know, how can parents even participate in multiple programs? And the answer is that if you build on family strengths and if you build on family goals, actually, you know, in this case, in this example on the left, as you get families to, as families attend more VIP sessions, they are more likely to attend more of the more intensive family checkup sessions in the home. And one thing that is very much the case in the US, but I suspect is the case everywhere, is that it's really hard to get families into those more intensive services. So I just want to show this as proof of concept in a paper. This is a paper by Dr. Canfield that I think is really important. The second example that I want to show is the something called the Pittsburgh study. This is a this is led by my colleague Danny Shaw, who is also together with Pamela Morris at Steinhardt and Danny Shaw at University of Pittsburgh, the principal investigators of the and me together, the principal investigators of the Smart Beginnings integration. Well, Danny Shaw has taken this one step further, and in Pittsburgh, working with his collaborators, they have developed a population level approach to layering services with risk stratification at population level, followed by, depending upon what level of risk, and you can see these are sort of the 4 levels that they've established, offering families a menu of programs based on risk. And, you know, PlayRead VIP and Family Checkup, two of the ones that and Smart Beginnings, which, as you know, I've been very involved in, are very central in this. But there are many low-touch programs as well, or lower-touch programs. And what's so cool about this is that this says, we're not saying you have to do this program or that program. Here are some options for you. You know, what is interest to you? And over time, maybe you want to choose something different. And maybe you don't want to do anything at all. So we really, this is something that we, that I think is a really powerful way of thinking at population level. Okay, so I just have a couple of more slides left, and then I'll stop for questions. I want to talk about our next steps to just end this talk. First is I want to sort of talk about the work that we're doing. We're doing a lot of additional initiatives. It includes sort of other integrations. Again, our goal is to work together with other programs. One of my colleagues, Dr. Canfield, has NIH funding to look at sort of layering this program with Healthy Steps, if you're familiar with that. I've sort of talked about integration across platforms. We've done a lot of work outside of primary care, and I mentioned some of them, but one other that I'll mention is that we're actually in the process of beginning to adapt and deliver this for family childcare providers. So another place where children, right, spend their days is in family childcare, and I can talk more about that if people want during the Q&A. I've sort of talked about some of these other adaptations that are out there, but some that I didn't mention were working with adolescent mothers. And then I mentioned that we've done some global work in Brazil. We're also beginning to do global work in Singapore. To support this, work, we've worked on getting certifications from the U.S. government, from the Prevention Services Clearinghouse, and we've really worked hard to understand, are there ways through systems in the U.S. and subsequently in other countries, how do we figure out how to sustain through building on existing reimbursement programs or strategies. And our goal, I'll just say what my goal is. My goal has been to implement and scale the program. We've set up a great deal of infrastructure to make that happen, including training and certification and maintenance of fidelity for the coaches. It's really important to do that because our coaches are not clinicians. They don't have advanced degrees. They're from the community, and developing train-the-trainer models. And this has led to some substantial expansion in the US, with us reaching, being in now 15 states and 15 sites in 4 states, and reaching several thousand families a year now. So I'll just conclude. This is my last content slide. I'll just mention that to my mind, the thing we have to be thinking about to get population level impact is layering of services, where we manage to get all families to have positive child experiences through universal support, through programs like Reach Out and Read, and universal availability of programs like Play Read VIP, which can then bring families from sort of foundational skills to mastery of early relational health skills. And then for the families who have adverse childhood experiences, doing other things as well, whether that includes family checkup and smart beginnings, or additional services through in healthcare or outside of healthcare through other programs, as you can see there. So I'll just mention that we've just, in conclusion, I'll just mention that we have received support from a number of different sources, including from NIH, particularly from NICHD, but now also from NIMHD, and New York City agencies, our work with the University of Pittsburgh and University of Singapore, and a number of foundations, including Tiger Foundation, Robin Hood Foundation, and the Klingenstein Fund, being 3 that are I can highlight here. And and a large number of co-investigators and collaborators in multiple locations. So I just want to really thank you for your attention, and I would love to talk more if you have questions or comments. Stop sharing.
Thank you, Dr. Mendelsohn. It was an amazing point of view of everything that you've been working on and analyzing all of the ACEs topic, but also looking into what we can do from this positive childhood experiences and the evidence just of this one project, but of all of the different projects that are being involved. And one of the questions that we have is, so this last piece that you talked about, the integration of services, because yes, it's not just talking about Play Read VIP, is what else is going on, and that's a good. But how do you, from the perspective of how do you fund many of these services so that we can reach out to the community? How are you doing it?
So, this is like the biggest issue, right?
Yes.
And it's going to be different in every locality in the US, and it's going to be different in every country. And,
Yes.
the good news is that, there is this increasing recognition of how important early childhood is as a foundation for, lifelong outcomes. And it's, and therefore, therefore, I think everywhere there are some opportunities. I think that the key in the US, from my perspective, the key has been to, we funded in a variety of different ways. We funded through research, we funded through philanthropy, and we funded through governmental. So like a hodgepodge. But what I see moving forward in the US is understanding what are the different mechanisms that are out there through, in the US's case, particularly Medicaid, and Medicaid is the U.S. governmental insurance that is the primary support, although not the only, for families with low incomes, and it supports others as well. So there have been a lot of opportunity for initiatives there. An example in New York, and this relates to many programs I think can utilize this, is Medicaid understanding the importance of social drivers and literally providing reimbursement for people called in the US community health workers to work and provide health promotion and prevention support for patients. And in the case of New York, it's really clear that the kind of work that we're doing and others are doing has the capacity to kind of be reimbursed through that. So I think, for my mind, in the US, reimbursement strategies are the key. I feel like and I'll mention that there are there have been lots of state initiatives that have relevance, some of which go through Medicaid and some of which don't, again across the U.S. And I was at the at the Pediatric Academic Society's meeting like several months ago, in Toronto, I think. And one of the last sessions I went to in that meeting was a session where it was great to understand that there are so many people in the US, and I think there were some people globally there too, who are sort of sharing this interest and sort of saying, okay, how do we make health systems work? So that's kind of one piece of it. I'll just mention that the other piece of it is is really advocacy and sort of looking to make sure that it's really well understood that one needs to do all of the different pieces. So like in the US, there's been a lot of, really most resources have been around adverse childhood experiences, IACEs, identifying families who have ACEs and referring them for services. Standard pediatric practice. We screen, we refer, right? And we, and we act, certainly when we can. But I mean, and for social drivers, that's mostly what we're going to do. I think that advocating so that early childhood stakeholders understand, sort of learn about how it's not just about ACEs. It's about the importance of how do you actually support early child development in a way that, can mitigate and buffer the effects of those ACEs. And that's why I think Christina Beffel's work is so critically important.
Yes. Yes. Now, as general pediatricians, which the vast majority that are here listening to this section, uh, we know that practice visits at the time, they're short. There are other things that are happening. And so I mean, you mentioned a couple of things, but like one or two tips for a general pediatrics practice on how to implement, or what are the first steps to implement one of these uh, interventions.
So I think the best place to start with that is reach out and read. I think that reach out and read is incredibly straightforward to implement, and that's one of the reasons why it has had such uptake in the U.S. and I think to some extent globally. It probably doesn't take more than like a minute to talk to a family about a children's book and engage in some degree of modeling, to be able to then further support the family. So the first thing that I would say is that I think that reach out and read is very straightforward in that regard. Another thing that is that, and I can't comment, about in Mexico, but I can comment in the US that there's a great deal of burnout by pediatricians or other pediatric providers. And what I think that giving pediatricians or other pediatric providers tools to be able to actually support in an evidence-based way, areas that I think we as a profession really value so much, I think has the potential to help us in the way we approach our jobs, our work with families. That certainly is my personal experience. I will say that from the perspective of Play-Read VIP, Play-Read VIP was specifically developed, to not. It's not taking place in the exam room. It's taking place in, I don't know, a place that's set off by a divider or a little closet that's been identified. And, in that circumstance, it's happening either before the visit or after the visit, but not actually during the visit itself. And, one is not going to reach every family at every visit in that way, nor is it designed to do so. What is the case is that it is, going to be potentially available to families when other issues are not intervening. And certainly everything you're saying, I totally agree with in that way.
Yes.
So I don't know if that.
Oh yeah. And following that, because this is how reach out and read is a good starting point. But what would you comment on the pros and cons of reading on a book on paper, images, colors versus screens? And I know you mentioned Jenny's going to be with us.
Jenny's going to talk. So she is like the world's expert on this topic.
Right, yeah.
Has done some of the major work. She and her colleagues, just noting that. So you're in for a great talk. However, what that work has shown is that one of the problems with electronic based books is that they're not necessarily designed to be read by parents. They can be designed to be used alone, even as a toy, and to the extent that they have, their claim to a lot of their claim to fame is, well, we have all these things, all these pop-ups, all these bells and whistles that are just so incredibly exciting. Well, they're being incredibly exciting means that there's going to be less engagement, not more, with the parent or caregiver. And what is critical, the reason why reading aloud and play is so important, right, is because it engages the parent and child, or the caregiver and child, together in a positive experience that supports their relationship. And so to the extent that one is working with an electronic modality, there are numerous possibilities for interfering with that happening. So that is sort of my short story on it.
Well, Dr. Mendelsohn, thank you very much. I mean, it was very nurturing, a different scope of what we're used to, of just general medicine and practice, and just looking into this view into family-centered practices. How can we implement things that at the end help on child development? So thank you very much.
It's my pleasure. It was to be here.
Thank you. Thank you very much, Dr. Mendelsohn. Thank you, Dr. Juan Francisco Lozano, for coordinating in this session and the rest of the series of this month. Muchas gracias a todos por su presentación, por haber asistido a esta sesión. Los invitamos a que la próxima semana se conecten, y en donde el doctor Juan Francisco Lozano presentará un tema muy interesante que son banderas rojas del neurodesarrollo. Todas aquellas cosas que como pediatras no se nos pueden escapar en el consultorio. Muchísimas gracias a todos y que tengan un excelente día.